Hello and welcome to day 2 of the St. Luke's, Kansas City Virtual Amyloidosis Symposium. My name is Dr. Furha Cossor and I will be your moderator for this afternoon. I'm joined here by my colleagues and co-hosts, Dr. Brett Sperry, Dr. Ibrahim Saeed, and Dr. Shahzad Raza, as well as our event planner, Dr. Rebecca Herzog. She just got a free doctorate. And we are more than happy and delighted that you all have joined us today for your day 2 of the symposium. Before we start, I'll remind you that each day the sessions will open for login about a half hour before the scheduled start of the session. We'll try to have our speakers stay within their allotted time, so allow you guys plenty of opportunity to answer or to ask questions. The speakers could ask questions to the audience, and you can actually type your answers, thoughts, any other questions you may have into the chat box there at the right-hand side of your screen. You can either send questions directly to me or to the group as a whole. If the speakers finish before the next talk is due to start, we can take a few questions. If not, we'll try and save the questions for the half-hour case-based discussion and Q&A for the end. And we can always add on any other questions there at the end as well. So for today, we'll be discussing the initial management strategies in AL amyloidosis. Our first speaker is my friend and colleague here at St. Luke's Cancer Institute, Dr. Shahzad Raza. Dr. Raza is an amyloidosis expert that previously worked at Columbia University in New York before he joined our group and started the Amyloidosis Center here at St. Luke's in 2017. He has a number of publications on amyloidosis, particularly in the use of monoclonal antibodies in this disease. And he is here to talk to us today on when to diagnose and when to treat MGUS versus AL amyloidosis.
Thank you, Dr. Cossor. And thank you, Dr. Cossor and Dr. Sperry. It's been a pleasure to be here. And today we're going to discuss about monoclonal gammopathy, when to diagnose and when to treat. Before we go to this topic, I just would like to focus. This is a clinical talk where my focus is our nurse practitioners, residents, fellows, cardiologists, neurologists, who have know about the amyloidosis, but try to learn a little bit more what it is, how it presents, and what are the clinical signs and symptoms they have to look for. And later during our session, we will deep dive into initial treatments and some renal manifestations. We have experts talk that's been subsequently after my talk, Dr. Sanchorawala and Dr. Picken will be discussing with you. So I feel that the first thing in amyloidosis always comes up that you need to diagnose this amyloidosis. If we don't diagnose, then those patients are unable to get to the hematologist or the right specialist so that they won't get treated. And that is one of the challenges that we see in our communities. And being worked in the Northeast population in New York City, busy urban population, and in Midwest. And I can easily tell you that both places, after working those places, yes, there is a significant knowledge gap, and that needs to fill with the knowledge and identification of these manifestations. So first we need to know what amyloidosis is. So yesterday we had a very extensive and detailed talk about how amyloidosis is, what's its pathophysiology. Just a basic few stuff that I would like to tell you that there are different types of amyloidosis. The amyloidosis type that we are focusing here, it's the light chain amyloidosis, which is a type of a cancer, a bone marrow cancer, which we define as a plasma cell neoplasm associated cancer, which produces misfolded proteins. And those misfolded proteins then eventually makes the fibrils, and those fibrils deposits to different organs and causes organ-directed challenges to our system, including cardiac issue, nerve issue, renal issues, and many others. Now, here is the cartoon that just tell you what this amyloidosis is. It's a very simple and basic diagram. You can see first there is a malignant plasma cell clone, which is a B cell clone. and they produce plasma cells. We have immunoglobulins. The immunoglobulins can eventually have misfolded light chain. So there is a problem here with the folding stabilization. And they eventually leads to fibrillar, prefibrillar aggregates, and eventually we have fibrillar aggregates. They can be directly toxic to the organ, or they can make fibril deposition to the different organs to our system. At the bottom, you can see how the patients can present, that there is a bilateral leg swelling. In the first slide, we have periorbital purpura, soft tissue infiltration like macroglossia, nail dystrophy, and the heart, which is the hallmark, what we see mostly in AL amyloidosis with low voltage QRS EKG changes and in restrictive cardiac myopathy. Now, you can look into that. There are certain biomarkers that we are looking for amyloidosis. And it's a key part for the clinicians. We really need to know which biomarker to follow, which one to really follow through with the patients. So you can see that our mitogen activated protein kinase P38 induces by the amyloid light chain fibrils. And it's the same pathway that our BNPs actually also induces that. So that's showing the connection about the biochemical markers that can correspond for you follow up for these patients who have organ damage because of amyloidosis. Now, this cartoon actually represents different organs involvement. Now, that was the publication from the blood back in 2012. And numbers keep changing, if you look at the proportion of the cases, we're still seeing more or less the same. Heart is mostly involved by AL amyloidosis, followed by kidney. And I would emphasize both organs really important to assess, because our majority of our patient population that we have seen, they mostly have heart and the kidney involvement. We sometimes encounter the liver involvement as well, and which is very challenging, and we'll go with some of the manifestations. And the rest, autonomic nervous system, peripheral nervous system. So bottom line is they can present with a different form and different ways. The clinician need to know all those manifestations so that he can do appropriate workup. Because if we miss the diagnosis, if we miss the presentation, we probably miss these patients from the diagnosis. That's why our incidence of AL amyloidosis diagnosis is very low, because probably we are not diagnosing these cases sooner. Now, in this slide, I just highlight some of the key findings, what we see. As far as the cardiac issues are concerned, we mostly see heart failure with preserved ejection fraction, thick ventricular walls, low voltage QRS complexes, and dyspnea and congestive heart failure related manifestations. In the GI tract, people can have either diarrhea, excessive GI complaints, explosive diarrhea, nausea, weight loss. That has been seen with the GI amyloidosis, but eventually, because it's involved, so people can also have constipation. So they can have different presentations. Similarly, in the nervous system, you can see either sensory motor neuropathies, carpal tunnel syndrome, which is very important. And we always in our clinic, we screen people and ask their history, particularly if they have any history of carpal tunnel syndrome. That keeps us thinking, because in some studies, approximately around 50% of the patients have somewhere the history of carpal tunnel syndrome is present. And the most challenging one, autonomic disturbances like syncopal episodes, lightheadedness. And here we need to really differentiate the neurological versus cardiogenic syncopal episodes. Those are, I believe, is very important. Now on the right side, I would emphasize on the liver involvement, because alkaline phosphatase elevation without significant ALT and AST elevation, that is something that's been seen with liver amyloidosis. And I have personally encountered a lot of challenging cases with the liver involvement in terms of the diagnosis and in terms of the management. But this is one of the key findings that we look for, especially the alkaline phosphatase. Macroglossia, periorbital edema, we already been discussed in the previous slides. In the kidney, I would defer to Dr. Picken when her talk will come up, but you can see anything in the renal side. I mean, when we were preparing the slides, we always look around nephrotic range proteinuria, but that's not always happen. I know this is a high level of suspicion for us, but it's not the always thing you will see it. Sometimes the proteinuria is very small, so you really have to look into the context of the clinical presentation. But the hallmark features, the key features for my colleagues in the internal medicine and cardiology, yes, nephrotic range proteinuria, that's something we really see with the renal involvement, and peripheral edema that we discussed in the previous slide. Some other pictures I would like to focus here, which we see in the medical textbook, if you're lucky enough to see, to read about amyloidosis, because it's not really common in our medical schools to read about this disease. So shoulder pad sign, again, with the soft tissue infiltrations, megaglossia. Now, I would like to show you figure A and D with some interest, because this was when I was a junior attending at Columbia University. So this is how I come across my first patient with an hand with some soft tissue swelling. You can see this patient has the swelling, and it was called as an amyloidoma. So we initially thought it's only an isolated swelling. This patient was about to start the treatment for rheumatoid arthritis. That's what his hands look like it. But look at it, we did a PET scan on this patient on the D slide. You can see how much this patient has soft tissue deposition on the shoulders and the joints. And that is something, another manifestation of amyloidosis. Eventually, it involves any organ with any presentations. You just have to have a very high level of suspicion. That's how the workup done. And then eventually we did the Congo red stain and immunofluorescence study, and we find out this patient has kappa restricted AL amyloidosis. Now, commonly hematological referrals, I personalize them based on my experiences, and obviously you may have different experiences in different centers, but this is how we generally seeing these patients. For number one is the diastolic heart failure, being managed by an experienced cardiologist, and then eventually they were referred to hematologists for evaluations. Recurrent pleural effusions, very important presentations. These are the patients who are really diagnosed very late, and they get the tapping of the pleural fluid, and then again they develop congestive heart failure, and those things continue to happen. And this is something we see a lot. Nephrotic syndrome we discussed. Sometimes we have a diagnosis of amyloidosis, like the clinicians, like our subspecialists, like skin dermatologists, they were doing the biopsy and they found the amyloidosis is present on the skin. And that's how we get the referral, and we work it up and find out whether this patient has localized amyloidosis or systemic amyloidosis. Bronchoscopy, it's very important. Sometimes our pulmonology colleagues, they went in for looking for some diagnostic or bronchoscopy, and they find out the patients have some findings of amyloidosis, and so they are referred to us. And we actually do some amyloid typing and do plasma cell dyscrasia workup to find out what type of amyloidosis is present. Peripheral neuropathy, autonomic insufficiency, that's are also very important referrals that hematologists usually get. And endoscopy and colonoscopic finding. Some of them are very incidental. So patients do not have symptoms, they are referred to us, so that's how we diagnose. But I would like to focus on number one and number two. Those are the key important ones, diastolic heart failures and nephrotic syndromes. That's where we really would like to catch those patients early before the damage already happened. And unfortunately, sometimes in hospital consultations, when the patients are really sick, have liver failure, end-stage kidney disease, heart failure, that's where we starting to diagnose these patients. And that's very unfortunate that those patients are diagnosed very late. Now, as a clinician hematologist, what we work, and this is my message to my other colleagues too, we get patients, they have only serum protein electrophoresis done. And that's how we get it. That workup is not enough for us. We really need to know more information about these things. Important thing is people can have serum protein electrophoresis normal. So we need to have especially serum-free light chain assay. It's a very important test. And that's what I'll go some cases to show you that's how we missed those cases in the past. So like 24-hour UPAP with immunofixation, those are very important. Clinical sign and symptoms, as we discussed previously, those are very important. Now, simple, easy test to perform is the fat PET biopsy as far as the suspicion of amyloidosis is concerned. And we really look for the Congo red stain. And then if there is amyloidosis is present, so we really want to type it with an mass spectrometry to confirm this is an AL type amyloidosis. Now, bone marrow biopsy, if there is a plasma cell dyscrasia is the reason that we do it, and we specifically look for certain molecular testing. Now our techniques are pretty advanced now. The FISH, particularly 1114 translocation, we look for that multi-parametric flow cytometry, that's very important, and plasma cell burden. And that's the hematologist bread and butter. That's how we work it up. And if the cardiac symptoms are present, we particularly would like to have an echocardiogram, and we look for certain key features. And MRI of the heart, since it's been now, a lot of hospitals now offer this test for AL amyloidosis, we really recommend them. Or if there is a suspicion of other type of amyloidosis, particularly TTR, then the PYP scan is offered as well. Now, this is with the request of my cardiology colleague to ask me about this free light chains. What are we looking for? So if you look at the free light chains, when we order this, and because this is the key test that we like to order in our patients. So first of all, it can be production-wise, it can be increased, or there is an increased metabolism. Infections, inflammations, someone who has rheumatoid arthritis, chronic kidney disease, they can all affect the free light chains levels. Now, at the bottom, I wrote the common numbers that we see it, but again, you will look into different things here. You look at the 95 percentile range that we follow, 0.26 to 1.65 as a light chain ratio. But you have to be very cautious when we look at this ratio, because this ratio can vary from the people to people. For example, you can see here back from the 2008 publications by Hutchison's group, you can clearly shows how our free light chains actually vary with the degree of renal involvement. And on the right, you can see that our dialysis modalities are also being affected with the ratio. So with this group, we come up with the new ratio, which is 0.37 to 3.1. And our free kappa continued to increase when the chronic kidney disease is starting to get worse. And we get these referrals a lot, and the docs usually get worried that free kappa is elevated. Again, we have to look at into the context of the renal insufficiency, and then appropriate UPAP with immunofixation and monoclonal proteins to really assess whether these mild elevations of the light chains are attributed to what? Basically, inflammation, renal insufficiency, or really a monoclonal protein disorder. Now, this slide is actually explaining some workup, what we do. So we know now about the sign and symptoms. Now we talk about nephrotic range, heart failure, non-diabetic neuropathy, hepatomegaly, diarrhea, atypical MGUS. And I would like to, when we have a case number 2, I will show you that what is atypical MGUS is. But in generally, you suspect the things, you start the immunoprotein workup, and if it's negative, you have comprehensively evaluated and you still suspected it, you can do the PYP scan and confirm patient has TTR amyloidosis or not. But if the immunoglobulin protein plasma cell dyscrasia workup is positive and amyloidosis is suspected, we start with the easy biopsy methods. Like fat PET is easily available in the hospitals, and we can do it and it can give us an answer. But please note, the fat PET biopsy is very much operator dependent, and it varies institutions to institutions. And I have seen challenges with the fat PET biopsy. One center is negative, another center is positive. So it does happen with the fat PET biopsy. But if it's positive, then you can look for the mass spectrometry and get your answer whether this patient has AL amyloidosis or not. Many times we have a challenge. We couldn't get it. We did multiple biopsies. We did the rectal biopsy, salivary gland biopsy, lip biopsies. We are not getting an answers. So sometimes we have to reach to the most affected organ where we are suspecting the amyloidosis. It could be a GI tract, which is endoscopy, colonoscopy, or sometimes the cardiac. So we have to go endomyocardial biopsy to confirm the diagnosis of AL amyloidosis. Now, this disease, if you see here, 9 to 14 cases per million per person year. Again, this is not really accurate in my opinion. Only reason is we have a lot more prevalent, but maybe we're not diagnosing these cases. Lambda's chronality is more common than kappa. You can see that median age is 63. For multiple myeloma, we are looking for age now 69. So you can see still in the 6th decade, we are seeing these cases. Males are more common. Ethnic data is not really accurate to really assess which ethnicities are more commonly affected. Maybe because it's underdiagnosed cases, what we are seeing. And then 1.3% of patients are diagnosed under the age of 35 years. And in my 5 years of career, only focusing on amyloidosis, I come across 4 to 5 very challenging cases who are less than 35 years of age. So yes, it does happen. It can present in your 3rd and 4th decade as well. Now, again, the different organs with a different biopsy, you can see how the sensitivity really varies with, again, operator dependent, and we have to combine as much as we can possible with a fat pad in the bone marrow in majority cases, but sometimes we ended up having the kidney biopsy, which is very important, especially nephrotic range proteinuria or AL amyloidosis involving the kidney. We do not have an answer. We are suspecting the amyloidosis is involved over there. So that's something we would like to mention. Okay, now we talk about the case. So I have 2 cases here, which will actually highlight the key parts here. Now, 66-year-old gentleman with history of recurrent pleural effusion was seen in the cardiology clinic. He has a diastolic failure with septal thickness of 15 millimeter, and he was managed with supportive care. And this is the case, I'm sure that a lot of our amyloid doctors have been watching this presentation. This is a very common presentation. Patient had no monoclonal protein in the blood, and I'm glad that the cardiologist thought at that time, and he had a PYP scan that was negative. Patient was reassured at that time, and he said, we do not have an amyloidosis, you do not have an M protein, and was not referred to the hematologist. Now, at some point, the patient was referred to hematology clinic for the second opinion. Now, here we did the serum free light chain very first time, and we find out, wow, the free lambda is elevated at 120 milligram per liter, and free kappa was 20. And we starting to do additional workup. We figured it out, patient has lambda monoclonal protein in the urine. Then we did cardiac MR consistent with amyloidosis, and the fat pad biopsy was obtained at that time, and it was positive for Congo red stain. We did additional testing and mass spectrometry, confirmed the diagnosis. And the bone marrow has a very small clonal population of 3% clonal lambda restricted plasma cells. This patient would have seen us 2 years earlier if we have done the right testing. And the right testing was, he should have a complete plasma cell dyscrasia workup, which does include serum-free light chain assay and the 24-hour UPAP with immunofixation. Only M protein, it can be negative. It's a low spike, low immunoglobulins level. Sometimes we don't see any protein, monoclonal proteins in that. So we really have to do the serum-free light chains and the urine testing to confirm that. This is the second case. So this is the 55-year-old gentleman was seen for evaluation of monoclonal gammopathy. As we all know, from our medical school, 1% per year, we're watching them, and at older they go, the MGUS rate increases, it can transform into multiple myeloma. That's a very common knowledge that majority of the training hematologist and the teaching hematologist, they know this finding. But here is the catch. Now, this patient has comorbidities, including chronic inflammatory demyelinating polyneuropathy, orthostatic hypotension, easy bruising, and he has this lambda 0.3, monoclonal lambda of 0.3 in the serum. On exam, he has a diarrhea every day in the morning, and he has orthostatic hypotension and had history of carpal tunnel syndrome 3 years ago. Additional workup shows elevated serum free light chains. You can see free lambda and free kappa, and the ratio was 3.15. And I would like to highlight the difference, because in amyloidosis, we particularly looking for light chain differences. That was 75 milligram per liter. And urine protein with immunofixation was negative. So he has a low dose whole body CT at that time that was negative for any sclerotic or lytic lesion. And he was diagnosed with MGUS, and observation was recommended. So this is not uncommon, and that happens among our specialty group as well. So was diagnosed with an MGUS. So those signs were really was not thought at that time that was related to amyloidosis. But if you know from the earlier slide, there were clearly a sign that these symptoms, signs are really concerning for AL type of amyloidosis. Now, for the second opinion, it comes in. So we started to do some additional workup. serum VEGF, which is very important because this patient has IgG IgM lambda monoclonal protein. So they can have POMs. So that's something for the neuropathy wise, we really would like to exclude them. So VEGF was normal on this patient. Now Waldenstrom, this is another type of MGUS can present with an kind of atypical MGUS that we are talking about. So you can see we did the MAG antibody titers, that was negative. Now it's good thought that we thought different type of neuropathy can be associated with plasma cell dyscrasia. He had a fat bed biopsy, which was negative. The bone marrow did show 9% clonal plasma cells and no evidence of Congo red stain. We did additional testing with an MYD88 mutation that was negative. PET scan was negative. Endoscopy was unremarkable. Now, because he has another complaint, diarrhea, and again, we have to chase the most symptomatic part. So here we did the colonoscopy and we did find patient has multiple polyps with positive Congo red stain and mass spectrometry confirmed AL amyloidosis typing. So the key part in this case is complete workup is very important. Patients with neuropathy should be investigated for plasma cell dyscrasia, which are associated with neuropathy, POMS, Waldenstrom, and amyloidosis. All three entities are very important. Now, this is the nice paper that was presented in an ASH. Now you can look at it. Patients who are referred to the hematologist with a diagnosis of MGUS, we sometimes say these patients have neuropathy. You can see the patients who have monoclonal gammopathy with polyneuropathies, they have an increased incidence of AL amyloidosis. And actually the incidence is higher in an early phase. You can see in the first year, they just jump. So I think we have to really carefully look for all those patients with MGUS, with neuropathy, with a proper evaluation, with an EMG studies, type of neuropathies, what they have, and the fat bed biopsy. At least we don't miss those cases in view of this data, which involves more than 15,000 patients. Now, some other specific tests we really recommend: EMG testing, nerve conduction testing. In our clinics here, we only do it case by case basis, only because it's not an easy test to perform and it is painful. So we really would like to do if we can change the management or if it has some additional information that we're looking for. Bone imaging, particularly if the myeloma is suspected along with amyloidosis, 10% or more plasma cells, we like to do it, or they are symptomatic with their bone pain. The staging markers are very important: NT-proBNP and troponin T, which I will go to the next slide about the staging. Or Dr. Sanchorawala's and then her group is actually has shown BNP and troponin I staging, which is also pretty comparable. LFTs and thyroid functions, coagulation studies. And if the bleeding is suspected, we always obtain the factor 10 level on these patients, factor 5 level if they have an advanced liver disease, platelet function studies, and acquired von Willebrand disease. And the gastric emptying studies, again, these are case by case cases, and we need really help from the other specialists who are also involved in the care of these patients, because for plasma cell dyscrasia treatments, along with that, we really need an organ-driven treatment for these patients so that we can maximally treat this patient to their best potential. Now, how we stage the amyloidosis? Now we have a suspicion, diagnosis. Now the staging comes up. So staging is based on the survival of the patient. We know we have different organs involved. They're not really involved in the staging. The cardiac staging is the key part, and that's the staging which is still commonly employed in the United States in many centers. We're looking for difference in the free light chain around more than 180 or 18 milligram per deciliter, cardiac troponin levels and NT-proBNP, and each thing has been marked with number of risk factors 0 to 3 and the revised prognostic stage from 1 to 4. And you can see that early stages, stage 1 and stage 2, have a prognostic staging 2. They have a better survival compared to stage 3 and stage 4. But this staging has some limitations, especially what Dr. Sanchorawala and her group has actually shown in her study. Patients who have chronic kidney disease, we lose the reliability of our NT-proBNP. That's number one. Number two, patients, NT-proBNP is not really available in all the centers. Troponin T is somewhere available, troponin I is available or some other institutions. So that's another staging that has been incorporated, and it's pretty much comparable. They actually compare with the Mayo 2004 staging system. So you can see the results are pretty comparable among the two groups. So either staging that can be used for our patients. but the focus is the staging is based on the cardiac biomarkers, because the cardiac biomarkers has direct association with the survival. Now, from the hematological perspective, last part is like, we look for the responses in our patients, like how they get the responses. So this is, you will see in the next couple of presenters who will talk about a lot about the VGPR or complete responses. So I just throw the slide here to just show you that here we are not really looking for the ratios, and ratios are only when we are talking about the complete responses. When we talk about the responses, we are looking for the differences between the light chains, involved versus an uninvolved. And that is something for my hematology colleagues, like how we assess the response. So VGPR, it's one of our benchmark that we really look for. And then if you're good enough, you can get your patients to the complete responses. And then you have an organ-directed responses, cardiac response, and the renal response, which has some validity with the way it's been defined. With somebody has an NT-proBNP of 650 or above, then you can actually calculate them. And then renal response, then you can see that the renal response is also important. So those responses comes late. They do not come early. It takes a longer time, and that's why the patients need to be informed that's not the response we are going to get in the next month. So responses are slow, but I like this this data because that was presented in 2018 by Dr. Dispenseri and her group. You can see that the cardiac responses comes up to 9.4 months, renal responses in 6 months, and the liver responses 6.1 months. These are the responses. Then it takes a time for getting the complete responses or the partial responses. So those organ responses does happen later if you get a good hematological responses to our patients. Now, in conclusion, I would like to say a few things here. Number one, it's an uncommon disease with a wide variety of symptoms. They are very non-specific symptoms, but there are some key features that we discussed here that we can look into and try to catch those patients early. High level of suspicion and knowing signs and symptoms are very important. I would like to tell you that many patients, we get it because the patients suspect that they have amyloidosis. That's another key part that we are really learning, that the patients come up and they tell us, okay, we are thinking this patient has amyloidosis. So that's another referral that are increasing on our population. So that's why I think our physicians really need to know the signs and symptoms, and the early referrals are very important. The right specialty with the right person, that's how we diagnose these cases early. And the workup should include the serum-free light chains, 24-hour urinary protein with immunofixations, and the serum protein lactophoresis with immunofixation. We don't think that FASCP is only is enough. We can miss those cases, and we have witnessed that in our setups. Now, mass spectrometry is the gold standard to confirm the amyloidosis typing. Yes, this approach has been employed in many institutions. Some people like to do immunofluorescence testing as well, but that's again operator dependent and high level of expertise is needed. But mass spectrometry is our gold standard here. And AL amyloidosis can present alone with the symptoms, or with multiple myeloma, or with Waldenstrom macroglobulinemia, or other types of lymphomas. So it's been seen with other diseases at the same time. So always look for it and try to diagnose them if you're really suspecting it. And I strongly recommend the referral to the tertiary care center. It's highly encouraged, especially for AL amyloidosis. And the reason is because the care of these patients usually involve different specialties, the cardiology, neurology, hematology, and nephrology experts, because we have to coordinate this care with the group. It's not only that hematologists can treat the light chains and make the patients in remission and control them. There are a lot of other challenges that we face with these amyloidosis patients. Sometimes difficulty intolerance, electrolyte balances, it's a challenging issue. And if we have all those support systems are available, I can tell you that we can make a difference to these patients' survival and their quality of life. Thank you.
All right, thank you very much, Dr. Raza. I think we are going to save questions for Dr. Raza until the end, because we appreciate you starting and finishing on time. So I'm gonna go ahead and introduce our next speaker. So if anybody does have questions for Dr. Raza, feel free to put them in the group chat. As far as our next speaker, I'm very excited that she was able to join us. This is Dr. Vaishali Sanchorawala. She has numerous publications to her credit on the initial treatment and use of transplant in AL amyloidosis. She is the director of the autologous stem cell transplant program at Boston University and on the board of directors for the International Society for Amyloidosis. We are honored that she has agreed to speak to us today, and she will be talking about initial treatment of amyloidosis, medications versus transplant considerations. So I will hand it over to Dr. Sanchorawala.
Hi, good afternoon, everyone. And I would like to thank the organizers for inviting me to this virtual amyloidosis symposium organized by the St. Luke's Hospital of Kansas City. I have been given the task of speaking about—
Dr. Sanchorawala, are you there?
Yes, I am. I'm talking. You can't hear me? Hello?
I could hear her.
Uh-oh. Hello?
I can hear you, hon.
Right, I know, me too. I can hear myself, but—
Okay, sorry about that. That was my technical problem. Go ahead.
Oh, okay, okay. And you can see my screen too, right?
Yes, yes, my fault.
Okay. Okay, so, it's an honor and privilege to participate in this virtual amyloidosis symposium. My task is today to talk about initial treatment for newly diagnosed patients with AL amyloidosis. Okay. These are my disclosures. I have been fortunate enough to participate in the expanding therapeutic landscape of AL amyloidosis. As you can see on this slide, the therapeutic landscape for AL amyloidosis has expanded dramatically in the past decade, and it continues to expand even further. I have divided my talk into treatment before the era of novel agents and treatment after the era of novel agents for patients with newly diagnosed AL amyloidosis. High-dose intravenous melphalan and autologous stem cell transplantation was developed for the treatment of AL amyloidosis in the early 1990s, and this treatment approach was prompted by promising results of similar regimens in multiple myeloma. Objectives of the initial clinical trials were to determine tolerability of this aggressive treatment approach in patients with multi-system organ involvement with AL amyloidosis. 2, to determine efficacy of this treatment in inducing complete hematologic response. And we argued that because the level of plasma cell burden in AL amyloidosis is lower than multiple myeloma, this treatment would be more efficacious in inducing complete hematologic response. And finally, to determine whether complete hematologic response leads to reversal of amyloid-related disease and improved survival. Prior to 1990s, 2 randomized pivotal clinical trials were considered the conventional treatment. The one was run by Dr. Skinner at Boston University Amyloidosis Center, and the other one was run by Dr. Kyle at the Mayo Clinic. Oral melphalan and prednisone improved survival of patients with AL amyloidosis with a median overall survival of 12 to 18 months. However, this form of treatment, oral melphalan and prednisone, rarely resulted in complete hematologic response, organ responses, and long-term survival. Long-term outcome of first 80 patients treated at Boston University Amyloidosis Center with high-dose melphalan and autologous stem cell transplantation was reported in 2007, showing that the median overall survival following stem cell transplantation, if patients achieved a complete hematologic response, was greater than 10 years and was 4.1 years for those who did not achieve a complete hematologic response. Novel anti-plasma cell therapies, in particular proteasome inhibitors and immunomodulatory agents, are questioning the role of stem cell transplantation in patients with newly diagnosed AL amyloidosis. Novel agents have been incorporated into stem cell transplantation in different phases, either as induction therapy or as conditioning regimen along with high-dose melphalan, as adjuvant therapy, or as consolidation therapy. A phase 2 prospective clinical trial of 35 patients performed at Boston University Amyloidosis Center tested induction therapy with bortezomib in 2 cycles, followed by bortezomib, high-dose melphalan, and stem cell transplantation for newly diagnosed patients with AL amyloidosis. In this trial, there were high rates of hematologic responses noted, with 63% of patients having hematologic complete response and 37% of patients having very good partial response. Furthermore, there was no negative impact of bortezomib induction on stem cell collection. However, 5 out of 35 patients, or 14%, who were eligible for stem cell transplant at the time of enrollment of this clinical trial did not proceed to stem cell transplant due to clinical deterioration during induction therapy. Long-term follow-up analysis of this trial was recently reported with a median follow-up of 77 months, showing that the median overall survival and progression-free survival were not reached. Hematologic relapse rates occurred in 15% at a median of 42 months, and organ progression occurred in 4% at a median of 37 months. Furthermore, renal and cardiac responses occurred in high proportion of patients at 65% and 88% respectively 5 years post-stem cell transplantation. A randomized controlled clinical trial from the Chinese group looked at 56 patients who were randomized to receive induction therapy with bortezomib and dexamethasone 2 cycles, followed by stem cell transplantation versus stem cell transplantation alone in the treatment of new diagnosis of AL amyloidosis with renal involvement. Hematologic complete response at 1 year and overall survival at 2 years favored the induction therapy followed by stem cell transplantation. HOVON 104 trial was reported recently for 50 patients with new diagnosis of AL amyloidosis who received 4 cycles of bortezomib-based induction therapy followed by stem cell transplantation. The hematologic response rate after stem cell transplant was quite high, with complete hematologic response of 46% and very good partial response of 26%. However, on an intention to treat analysis, hematologic complete response was 32%, and this led to conclusion of the trial to be futile because the pre-planned statistical analysis was not met based on intention to treat analysis. In this trial as well, 15 out of 50 patients, that is 30%, did not proceed to stem cell transplantation due to complications that occurred during induction therapy. So induction therapy should be used with caution prior to stem cell transplantation in patients with AL amyloidosis, as complications during induction treatment can make patients ineligible for stem cell transplantation, which is the most definitive treatment. Mayo Clinic investigators have also noted that bone marrow plasmacytosis affects survival in AL amyloidosis in these 2 separate publications. We examined at Boston University Amyloidosis Center role of induction therapy prior to stem cell transplantation based on bone marrow plasmacytosis of greater than 10%, and we noted that there was no difference in overall survival for patients who received induction therapy prior to stem cell transplantation, irrespective of the bone marrow plasmacytosis. Novel agents have been incorporated after stem cell transplantation, either as adjuvant therapy or as consolidation therapy, and these investigations have been led by the investigators at Memorial Sloan Kettering Cancer Institute. And as shown here, novel agents given after stem cell transplantation can improve the depth of hematologic response following stem cell transplantation. Maintenance therapy, on the other hand, has not been studied in clinical trials and is not recommended routinely as standard of care following stem cell transplantation. Nonetheless, ixazomib maintenance is being studied as a maintenance after stem cell transplantation is being studied at in a clinical trial at Memorial Sloan Kettering Cancer Institute, and this trial is led by Heather Landau. We at Boston University Amyloidosis Center looked at long-term results of stem cell transplantation in patients with AL amyloidosis over a 20-year period from 1994 to 2014 to address durability of hematologic response and to address long-term survival of patients undergoing this treatment. Eligibility criteria have included tissue diagnosis of amyloidosis, evidence of a plasma cell dyscrasia, and at least one vital organ involvement with minimum measures of performance status, cardiac function, pulmonary function, and hemodynamic stability. 629 patients have been treated on several sequential IRB-approved clinical trials, and age, renal function, time from diagnosis, prior treatment, and conditioning regimen have varied among clinical trials. Exclusion criteria for these protocols have included exercise limitation with less than 2 to 3 flights climb during pulmonary function tests and/or oxygen uptake of less than 15 ml per kilogram per minute on cardiopulmonary exercise study, direct hyperbilirubinemia of greater than 2 milligrams per deciliter, and advanced cardiac involvement with markedly elevated cardiac biomarkers. 629 patients with AL amyloidosis have undergone stem cell transplantation from July of 1994 to December 2014. The median age is 57 years, and more than half of the patients had cardiac involvement, and 40% of patients had greater than 2 organ system involvement. Majority of the patients have received full high-dose melphalan at 200 milligrams per meter square, and 45% of the patients have received modified high-dose melphalan at 100 to 140 milligrams per meter square. Treatment-related mortality, defined as deaths within 100 days after stem cell transplant, occurred in 7.4% of the patients, and majority of these patients had significant cardiac involvement. Early mortality rate is reduced to 3.4% since 2005. It is important to note there were 11 deaths, that is 2%, during stem cell mobilization and collection phase of treatment. And in addition, there were 5 deaths during stem cell infusion procedure. This denotes the medical frailty and complexity of these patients while undergoing stem cell mobilization and collection phase of stem cell transplant treatment. Hematologic complete response measured at 6 to 12 months occurred in 40% of the patients following stem cell transplantation. On an intention to treat analysis, hematologic complete response occurred in 35% of the patients. Hematologic complete response was more commonly seen in 45% of the patients who received full high-dose melphalan compared to 34% of the patients who received modified high-dose melphalan. Median overall survival for 629 patients who have undergone stem cell transplantation is 7.6 years, with 30% of the patients achieving long-term survival of greater than 20 years. Hematologic relapse, defined as recurrence of plasma cell dyscrasia after achievement of a complete hematologic response following stem cell transplantation, occurred in 32% of the patients at a median of 4.3 years, ranging from 1.5 to 21.5 years. Again, it is important to note that relapses can occur even after 20 years of a follow-up. Biochemical relapse, defined as reappearance of monoclonal gammopathy on serum or urine immunofixation electrophoresis without abnormality of the serum free light chain assay, occurred in 16% of the patients, which did not require additional therapy at a median of 6.5 years. Median overall survival following hematologic relapse is 8.5 years. Nephrotic syndrome also improves following stem cell transplantation. 70% of the patients had reduction in proteinuria by 50% after achievement of a hematologic complete response compared to 30% of the patients who did not achieve a hematologic complete response. Quality of life, as measured by short form 36, also improves following stem cell transplantation. Mental component summary and physical component summary of SF36 improved and reached the population norm by 2 years following stem cell transplantation. Big livers also shrank following stem cell transplantation. Hepatic response, defined as greater than 30% reduction in enlargement of the liver or a 50% decrease of an elevated alkaline phosphatase levels, occurred in 60% of the patients following stem cell transplantation. Cardiac responses, as measured by contemporary measures of echocardiography and cardiac biomarkers, were also evident following stem cell transplantation. Apical to basal ratio, as well as cardiac biomarker of BNP, improved significantly for those who achieved a complete hematologic response compared to those who did not achieve a complete hematologic response. The largest experience of stem cell transplantation in AL amyloidosis comes from the registry data of CIBMTR, looking at 1,500 patients and 5-year overall survival. 5-year overall survival has improved dramatically from 55% in the mid-1990s to 77% in 2007 to 2012 years. Mayo Clinic also recently published their long-term outcome of stem cell transplantation in AL amyloidosis with an estimated 15-year overall survival of 33%. Similar results were reported by the United Kingdom National Amyloidosis Center in 264 patients treated with stem cell transplantation in AL amyloidosis with a median overall survival of 8.2 years and long-term survival at 20 years of 33%. Unfortunately, there are no direct comparison of non-stem cell transplant regimens to stem cell transplantation in AL amyloidosis with respect to hematologic response, overall survival, progression-free survival, organ response, and quality of life measures. Except for the IFM or multicenter French clinical trial, which enrolled 100 patients randomized to either oral melphalan dexamethasone or high-dose melphalan stem cell transplantation. In this trial, oral melphalan and dexamethasone did much better than stem cell transplantation with respect to overall survival. This trial has been criticized and is controversial because of high treatment-related mortality that was experienced on the high-dose melphalan stem cell transplant arm of 26%, negating the benefit of stem cell transplant in overall survival. Only 20 to 25% of patients with newly diagnosed AL amyloidosis are eligible to receive stem cell transplantation, even in centers with experience and even in centers with liberal eligibility criteria for stem cell transplantation. The non-stem cell transplant treatment regimens, which are commonly used as standard of care, are either oral melphalan dexamethasone or combination of cyclophosphamide, bortezomib, dexamethasone. Two large papers published from the University of Pavia, the Italian groups, are listed over here. 259 patients who were not eligible to receive stem cell transplantation received oral melphalan and dexamethasone for AL amyloidosis. When attenuated dose of dexamethasone was used, which is 20 milligrams weekly dose, which is commonly used in the United States of America, the complete hematologic response was 12% and the median overall survival was 20 months. 230 patients who were not eligible to receive stem cell transplantation were treated with cyclophosphamide, bortezomib, dexamethasone, Cybor-D regimen, and when intermediate or low dose bortezomib, which is weekly bortezomib at 1.3 milligrams per meter square, was used, which is the most commonly used regimen in the United States of America, the complete hematologic response rate was 19%. How about the overall survival? When low-dose attenuated weekly dexamethasone was used for oral melphalan dexamethasone, the median overall survival was 20 months. For Cybor-D paper, with a median follow-up of 25 months, 3-year overall survival was 55%, and the median progression-free survival was 13 months in this Italian paper. Recently, UK National Amyloidosis Center reported on 915 patients who were treated with upfront bortezomib treatment for those who were not eligible to receive stem cell transplantation. And as shown here, the hematologic complete response in an intention to treat analysis occurred in 25% of the patients, and hematologic very good partial response occurred in 20% of the patients. The median overall survival was 72 months, and median time to next treatment was not reached. I would also like to report on the safety run-in results of Andromeda clinical trial. For those who are not familiar with this clinical trial, this is a phase 3 randomized international global multi-center clinical trial of newly diagnosed patients with AL amyloidosis who are randomized to receive Cybor-D, standard of care, versus Cybor-D plus subcutaneous daratumumab. The safety run-in results are reported here and recently published, where patients received Cybor-D plus subcutaneous daratumumab. And as shown here, that the hematologic complete response occurred in 54% of the patients, and hematologic partial response occurred in 29% of the patients. Organ responses were also evident on this safety run-in data, with cardiac response occurring in 53% of the patients and renal response occurring in 83% of the patients. This trial is close to accrual, and final analysis of the phase 3 trial is awaited. Mayo Clinic investigators also reported their experience on patients with stem cell transplantation and non-stem cell transplant regimens. We will focus on the later period of 2010 to 2014, and in this particular time period, 2-year overall survival with stem cell transplantation was 94%, and 2-year overall survival with non-stem cell transplant regimens was 47%. Bear in mind, these are not randomized clinical trials. This is experience of Mayo Clinic in the same time period. How about the progression-free survival? Progression-free survival in the same cohort of patients from the later time period of 2010 to 2014, the 2-year progression-free survival was 73% for patients undergoing stem cell transplantation compared to 30% for those who received non-stem cell transplant regimens. We at Boston University Amyloidosis Center reported on the longitudinal analysis of quality of life based on short form 36 in AL amyloidosis. Percentage of patients with clinically meaningful improvement, particularly in physical component summary and mental component summary following stem cell transplantation occurred in 41 and 47% of the patients. Similarly, percentage of patients with clinically meaningful improvement following non-stem cell transplant regimens occurred in 23% of the patients for physical component summary and 29% of the patients for mental component summary. So take-home messages: long-term outcome and results of stem cell transplantation in selected patients, highly selected patients with AL amyloidosis are unprecedented, with 30% of patients alive for 20+ years. Moreover, stem cell transplantation can lead to durable hematologic complete response with low rate of hematologic relapse. Novel therapies, in particular monoclonal antibodies as well as proteasome inhibitors, can lead to high hematologic responses. However, durability of these responses is not known off therapy and follow-up times are quite short. I would like to conclude by acknowledging many members of the clinical and basic science multidisciplinary teams that work on the scenes and behind the scenes to make this disease a chronic manageable disease. And thank you for your attention.
Thank you so much, Dr. Sanchorawala. That was a fantastic talk. Unfortunately, we don't have time for questions right now, so I'm going to collate the questions that we got during your talk and save them for the end. Right now, we need to move on. The next speaker and our third and final speaker for today is Dr. Maria Picken. She is the Director of Surgical, Oncologic, Solid Organ Transplant, and Renal Pathology departments at Loyola University Medical Center. She is an expert in renal manifestations of amyloidosis, and she is widely published on the topic from a pathology perspective. And so we are very excited and thrilled that she could be here to discuss with us renal manifestations and pathology in renal AL amyloidosis. So I'll turn it over to you, Dr. Picken. Oh, we need to unmute you. Here we go.
Muted.
Oh, there we go.
Okay, thank you. Hello, everyone. And it is a difficult task for me, a pathologist, to follow after my very famous predecessors. As you've heard, I am a pathologist with interest in kidney diseases and amyloidosis. And today I will talk about renal manifestations and pathology of AL amyloidosis. Okay. Just a moment. Okay, the goals are as listed here. So today, at least 36 different proteins are known to form amyloid fibrils in humans. Amyloid deposits may be systemic or localized, can be found in various organs or tissues throughout the body. Kidneys are involved essentially in all types of systemic amyloidosis, although to a variable degree. So it is important from the clinical point of view to recognize which amyloid types are treatable versus those which are not treatable and which have a genetic component. This table is somewhat simplified. At the very bottom, you have localized cerebral amyloidosis, which we are not going to touch today. Further from the bottom, various localized amyloidosis, which again, we will not talk about. And here toward the top, we have systemic amyloidosis. And at the top, we have three main acquired types. And then as number 4 is a rather heterogeneous group where we have mostly hereditary amyloidosis. And notice that most of these different amyloidosis types are listed here as involving kidneys. Several also involve the heart. You will hear more about heart during this meeting later on. So our number 1 differential diagnosis as far as systemic amyloidosis and renal amyloidosis in particular is concerned is AL amyloidosis, amyloidosis immunoglobulin light chain. Roughly, it is estimated that it accounts for about 85% of systemic amyloidosis in the developed world. This data regarding the prevalence is changing all the time. I wanted to draw your attention to the fact that there is a significant increase in number of cases which we diagnose in the more recent years. And maybe it is because finally we are doing a better job diagnosing those. As it was alluded to previously, AL is associated with the clonal plasma cell proliferation. These cells produce monoclonal protein, which circulates in blood and deposits as systemic. You see all these external signs, and the main sites of involvement are kidney, the heart, peripheral neuropathy. Now, AL is an example of an M protein related disease. And Dr. Raza mentioned that AL can be either in association with myeloma or by itself. And this is what being by itself refers to this M protein related disease. So if we take a look, excuse me, at this cartoon. On the left side, we have an example of a B-cell neoplasia, such as, for example, multiple myeloma. And here we have a, sizable clone. And the patients have clinical manifestations due to the clone as well as due to the M protein. Manifestations due to the clone are bony lesions, which we know are myeloma defining feature, hypercalcemia, infections, systemic symptoms. Clinical manifestations due to M protein, light chain cast nephropathy, hyperviscosity, and only about 10 to 15% of patients will have AL amyloidosis. The great majority of patients, about 85% of patients with AL, have small clone size, such that most of the time they have no manifestations, no clinical manifestations due to the clone, but yet they have enormous gravity, very severe manifestations due to the M protein. And here is light chain amyloidosis, AL, There is also light chain deposition disease, light chain proximal tubulopathy, etc. I would like to refer you to this expert consensus document listing a variety of other conditions. So it is important to keep this image in mind, and it will help us to understand why so many times it is so difficult to nail down patients with light chain amyloid, because we don't see much here, okay? And we need to make sure that we detect what's happening here, okay? And people frequently write about these small clones as a small but dangerous clone. I believe that Merlini was the first one to use this term, and I will not go into the reasons why we think it happens. It is that these light chains produced by this small dangerous clone are very peculiar and very unstable and prone to fibrillogenesis, to say the least. And in terms of treatment, as my predecessors alluded to, we need to target the cells themselves, and the treatment, equally aggressive, is also applied to this small but dangerous clone. Now, in terms of kidneys, most patients with light chain amyloidosis have glomerular deposits, okay? This is a glomerulus, these little specks are deposits of amyloid, and most patients present with proteinuria, many with nephrotic syndrome. And in an adult patient, non-diabetic patient, the presence of the nephrotic syndrome in particular is an indication for a kidney biopsy. And this is a big help in earlier diagnosis of patients affected. But delay in diagnosis of proteinuria can happen, and does happen, for a variety of reasons. There are confounding factors, for example, diabetes. It's very easy to assume that the proteinuria is due to diabetes. Proteinuria may not always be obvious, can progress very slowly. Edema can masquerade as heart failure in older patients. And of course, we also know that free light chain proteinuria will be missed on urine dipstick. So this very important sign, proteinuria nephrotic syndrome, is frequently not utilized soon enough in workup of patients with amyloidosis. Moreover, as the Mayo Clinic group published several years ago, a paper, not all patients with AL have significant proteinuria. A small fraction, about 5% in their study, had vascular limited light chain amyloid, and as expected, they had very minimal proteinuria, but they had, in contrast, much higher level of serum creatinine associated with a more advanced renal failure. So this group of patients fell into category of renal failure, and renal failure is a little bit like cardiac failure. The differential is very broad, and amyloidosis does not come to mind at the top of it. So, you know, the diagnosis of amyloidosis is based on tissue. This is the current gold standard. All the other radiology and other studies are being compared against this gold standard. Amyloid is fibrillar only by electron microscopy. What we are looking for in the routine histology are these homogeneous areas, which are by themselves not specific. We need to do the Congo red stain, examine it under polarized light, and this is how we detect amyloid, not just AL, but any type of amyloid, because there are these Congo red binding sites, which are essentially beta pleated sheet structure specific. So, in terms of detection of amyloid, you may notice that many times, even nowadays in the literature, you see images of the kidney. These are glomeruli in the routine stain, H&E. This is a Congo red stain under polarized light, and they look completely obliterated. This is end-stage kidney. This is our failure. I am actually sorry to see images like that in the literature, because we already missed the boat. There is no way we can recover function in this organ. This is too far advanced. What we want to catch the disease, when we want to catch the disease, is more stages like these, where we have very small, minute areas. And this is glomerulus with the earlier deposits of amyloid, which are much smaller. So this is our goal. Early amyloidosis can be missed. It mimics minimal change disease, focal and segmental glomerular sclerosis, diabetes. Hence, we need to do Congo red stain, not only to confirm our suspicion based on H&E stain, but also to rule it out. And I think you as clinicians should really make sure that the pathologists don't forget to do it, that they don't just stop reporting one diagnosis and consider that, oh, we probably don't need Congo red. Congo red stain is inexpensive, and it can be extremely helpful, in particular in the kidney biopsy, in earlier detection of amyloid. But this is not the end of the story. This is a little bit complex, complicated slide. In terms of amyloidosis pathogenesis. So it's not only light chain, but any type of amyloidosis. We begin with the precursor protein, right, which undergoes misfolding, then forms these oligomers, protofibrils, and then further down the pathway, SAP, serum amyloid P component is recruited, GAGs, glycosaminoglycans, and then finally we see the fibril. And at this stage, yes, we can see fibrils with electron microscope. We can see also deposits with Congo red stain. But there is evidence that the toxicity of amyloid, referred to as proteotoxicity, already begins at this stage. And we actually don't detect amyloid, at least in the clinical setting, at this stage. So our goal should be not only to detect as early Congo red positive deposits, but maybe prospectively to look into being able to detect it here. And I think that keeping in mind this diagram will help you, for example, in the clinical situation that you have a patient with AL, you treat, reduce rapidly the levels of serum-free light chains, the patient feels much, shows clinical improvement, but yet if you think about the volume of amyloid deposits, not much has changed. And that's because at this stage, the proteotoxic activity has been diminished. Okay, so that's something to look forward in terms of future. I will not talk about Dr. Raza already alluded to, and Dr. Sanchorawala, about the responses and stuff like that. But I would like to focus, in the interest of time, on pathology. So in terms of the kidneys, when I have a kidney biopsy, I'd like to think about, keep this image. So about 6 patients are most likely to have light chain amyloid, but for every 6 patients with light chain amyloid, I should have at least 1 with something else. And this something else is quite heterogeneous, okay? We have AA, this inflammatory amyloid, ALEC2, and then hereditary amyloidosis. Some are maybe familiar to you. There are also some which are clearly very rare, zebras, and it is extremely important to avoid misdiagnosing those as AL, which we see all the time, I should say. So with this introduction, let's take a look at the old friend AA. This is the second most common systemic amyloidosis, although I have to say that we don't see it, or we at least don't recognize, don't diagnose it probably often enough. So there is the amyloid fibers are derived from serum amyloid A protein, which is hepatic acute phase reactant. Deposits are systemic. The main target is on the kidney, but then there is the liver, spleen, and GI tract. And in the US, AA contributes maybe to about 5% of renal amyloidosis. It's probably underreported. Worldwide, it is said to be the second most common type of systemic amyloidosis, but in the developing countries, AA is more common than AL. And please keep in mind that AA amyloidosis is not a uniform disease. We have sporadic forms, we have familial, and then patients with the covert disease. Sporadic amyloidosis in the developed countries is associated with chronic inflammatory conditions like arthritis, less often chronic infections, certain tumors. Now, familial AA amyloidosis is associated with conditions known as hereditary autoinflammatory diseases. And here the genetic component is not in the amyloid protein precursor itself, but it is in the proteins which are responsible for handling the inflammatory response, and in particular of the innate immune system. And I will show you examples of that in a moment. And then we identify ever-increasing subset of patients who develop AA amyloidosis seemingly with no identifiable disease. And I want to tell you that similar to AL, there is plenty of options for treatment available, which I will not even touch upon today, but it is treatable. Okay, so hereditary autoinflammatory diseases can be monogenic, polygenic. Monogenic, maybe some of you heard about familial Mediterranean fever. So if somebody is coming from this area, you may consider that this is autosomal recessive hereditary disease with recurrent attacks of fever, peritonitis. Patients may have this erysipelas-like skin disease, and the most dreaded complication of this disease is renal amyloidosis. The disease can be managed, can be treated, so it is important to recognize it. Now, we do recognize in this country more patients with inflammatory bowel disease developing AA amyloidosis, and this is associated with polygenic or complex hereditary autoinflammatory diseases. So think about it. Now, what about the last group, the covert AA? With the improvements with modern therapies, of course, the incidence of AA is going down. But at the same time, we see rise in number of cases with unknown etiology. And this is data from the London Amyloidosis Center, where they showed that in the more recent decade, almost a quarter of the patients belong to this group. What we see in this country is increase in patients with chronic infection due to IV drug abuse. But take a look at this. This is an emerging obesity as a susceptibility factor. We may see more AA amyloidosis associated with that. With that, one sort of has to wonder what is the possible genetic component in sporadic AA. It is true that you need a chronic inflammatory process to develop AA, but at the same time, not every patient with chronic inflammatory response develops AA. So there is more for us to learn about it than I will have time to talk, okay? Now, most of the patients will present with the proteinuria. The amyloid affects kidney in a diffuse fashion, including glomeruli, but about 5% of patients with AA will not have any significant proteinuria. They will have deposits of amyloid in the medulla. Okay, and it is important to recognize those because then treatment has to be more intensified in order to prevent progression. So we've covered AA. Now the third type of systemic amyloidosis, ALEC2, stands for amyloidosis derived from the leukocyte chemotactic factor 2, the third most common systemic amyloidosis type. And here up front, I have to say that there is currently no effective treatment for this particular type of amyloidosis, and importance in diagnosing this particular type is that we do not misdiagnose it as AL. And patients who were misdiagnosed with this amyloidosis, who were misdiagnosed with AL, have been incorrectly offered chemotherapy and stuff like that. So this is something to avoid. Etiology is unknown. There is no mutation. There are some peculiarities in the genotypically. Disease is systemic, but mainly affects the kidney, the liver. Jonathan Wall yesterday showed also adrenal gland. So clearly systemic, but kidney the most clinically obvious. Typically, there is slowly progressive renal failure. Older patients, and there is this very peculiar ethnic bias, Hispanics, particularly Mexican American. Now, in terms of clinical picture, yes, the initial reports were stating slowly progressive renal failure, no significant proteinuria, and deposits of amyloid predominantly in the interstitium. But as we see more specimens, more patients, it occurs that some patients also have glomerular deposits, and they may have some degree of proteinuria as well. Hence, I would like to emphasize here that amyloid type cannot be diagnosed based on amyloid distribution. You can have your sort of favorites in terms of differential, but the amyloid type has to be done properly, not based on the distribution. Now, what about this ethnic association? These dots show places in the world where ALEC2 has been reported. Notice there is a notable absence from Europe. The only European study published is from London, but if you look at the origin of the patients, they are all other origins than British Caucasians. In the US, we say that this is a third type of systemic amyloidosis, but in the Southwest, the ALEC2 is more common than AL. So please keep it in mind. And finally, I hope I'm not going to be kicked out here. I speed up, I promise. The fourth group, our number 4 differential diagnosis of amyloid type, hereditary amyloidosis. Individually, they are rare, but collectively, they may account up to 10%, and we probably don't diagnose them well enough. So here in hereditary amyloidosis, the mutation affects the amyloid protein itself, okay? And the mutation renders the protein amyloidogenic. It makes it less stable and stuff like that. There are phenotypic differences. The transthyretin hereditary amyloidosis is the most common, but there is also amyloidosis derived from fibrinogen, several apolipoproteins, gelsolin, etc. And most of them are produced primarily or exclusively, some by the liver. And you heard a little bit yesterday from Jeff Kelly about the liver transplant and stuff like that. I will not talk about it. Now, hereditary transthyretin amyloidosis, yes, you are mostly associating it either with cardiopathic phenotype or neuropathic phenotype. Some patients may have both. And it is true that the mutant which is most prevalent in the US, which affects close to 4% of African Americans, this particular mutation is not associated with clinically important renal amyloidosis, but other mutations, for example, V30MET, which is seen in these hotspots as well as in the US, can be associated with significant renal involvement. So keep this in mind. There is a lot of phenotypic overlap between hereditary ATTR and AL, and misdiagnosis has to be avoided, and patients diagnosed with potentially hereditary amyloidosis need molecular gene sequencing. In terms of others, hereditary amyloidosis, there are several apolipoproteins, and apolipoprotein A1 is the most common. It is probably the second most common systemic hereditary amyloidosis. And here, these patients don't have significant proteinuria. They don't have glomerular amyloid. This is a kidney section in the deep medulla. And here deposits of amyloid are located deep in the medulla, such that the patients have renal failure. And it is relatively easy to imagine a scenario when the biopsy does not contain enough of the medullary sample that the diagnosis can be missed altogether. Now, there is no specific treatment available at the present time. Kidney transplantation has been done with reasonable results, but it is important to diagnose these patients, to sequence. Phenotype varies with the location of gene mutation. There are associated phenotypic abnormalities which need to be addressed. There is also ApoA2, which is primarily nephropathic, and then other which are much rarer. Amyloid derived from fibrinogen is more seen in Europe, in the UK, Portugal. It has a very characteristic pathology. It tends to affect the glomeruli preferentially, so the patients present with the nephrotic syndrome and hypertension. And the family history is frequently missing. So again, the same word of caution that we need to make sure that the diagnosis is based on solid data. And finally, a real zebra. This at the first glance would make you think about yet another case of light chain amyloidosis. Well, not so fast. This is actually from the lysozyme amyloidosis, which is a rare disease indeed. Now, can I carry on, or are you going to cut me out?
No, you can, I think you have a few more minutes left.
Yeah, okay. All right. So please keep in mind, and this is the main message, avoid misdiagnosis as AL. Okay. Now, in terms of kidney, I think we, looking at the kidney biopsy, have it a little bit easier, providing we do our work properly and don't cut corners, because the differential diagnosis of proteinuria is relatively short, okay? Focal and segmental glomerulosclerosis, minimal change disease, membranous nephropathy, diabetes, and then amyloidosis comes as number 4, okay? So it is much easier than in the heart or in particular peripheral nerve. But I also want to say that I see more and more GI biopsies which come on my desk and where we detect amyloid. Amyloid typing, yes, I want to emphasize it has to be done properly, cannot be based on clinical laboratory studies alone. These can support the diagnosis, but not make it. Caution is advised because a significant proportion of patients with ATTR, for example, have MGUS. Dr. Sanchorawala and her group reported on this extensively. And we have been using immunohistochemistry versus mass spectrometry. Mass spectrometry is the way to go with paraffin-embedded tissue, but just one word, that in the kidney biopsies in North America in particular, we still use frozen section immunofluorescence for evaluation of kidney biopsies. And this is done routinely, and essentially all laboratories should include staining for FASCP and lambda light chain. So as a first step in amyloid typing, one can detect light chain restriction and diagnose light chain amyloid in a significant proportion of cases. Again, not all cases. So this could be done, and use of frozen section immunofluorescence is a little bit like drinking. It has to be done responsibly with knowledge of the limitation. And when there is any shadow of the doubt that the light chain restriction is not strong enough, not clear enough, one needs to support the typing with other methods, and mass spectrometry is the way to go. I will not talk about FAT, but I want to, or actually wanted to mention, since Dr. Raza talked about operator variability. Yes, I agree, you want to get real fat, but what I recommend using in particular, if we have a strong suspicion and we are not able to see in the fine needle aspiration biopsy, I go with a little surgical biopsy, which gives me a lot of material to work with. Notice that there is a difference in sensitivity for diagnosis of different amyloid types, and fat biopsy works very well for light chain and AA, not so well for other types, okay? And finally, bone marrow biopsies are great. We do it for light chain amyloid, but I also want to emphasize that bone marrow biopsy specimen is actually a source of potentially diagnostic tissue. And there is a data, and we also reported recently, that you can have amyloid in the vessels in patients with AA. In particular, these soft tissues hanging by the bony fragment, you can have ATTR and potentially also other types. So I strongly recommend using fat biopsy, if needed surgical biopsy, and looking really well at the bone marrow biopsy, not only looking at the marrow itself, but also at the extramedullary tissue. And to conclude, yes, early and accurate diagnosis is essential, and we need to work together to make sure that patients are diagnosed as early as possible. And the importance of proteinuria, because it offers a very good opportunity to embark on the proper differential, providing we see what's before us. Thank you.
Thank you so much, Dr. Picken. That was an amazing talk. I think we have a lot of very good questions. If you're willing to stick around for the next 25 minutes or so, along with Dr. Sanchorawala and Dr. Raza, I wanted to first pose, we had one question to specifically Dr. Sanchorawala. Let me scroll back and find that. Dr. Sanchorawala. Okay. All right. Well, maybe let me start with the question for Dr. Raza. So Dr. Raza, we had a question earlier regarding the use of BNP versus regular BNP. Let me see if I can find that. So specifically, someone wanted to know if you adjust for the renal function when doing cardiac staging using pro-BNP or NT-pro-BNP.
So it's a difficult question to answer. It's a difficult question to answer with accuracy because we have very validated tool previously with an NT-proBNP in the setting with troponin T that based on the cardiac risk factors and the cardiac amyloidosis. Now, we are learning a lot more about how to interpret them. But if you look at the Mayo data, that also suggests that regardless if they have a cardiac involvement present or not, if they have NT-proBNP is high enough, it's even though you're not picking it up, the cardiac involvement, but it's still very highly suspicious for the cardiac involvement, and they have a tendency to do bad because basically you're looking for the staging. So there was no adjustment in that study to the best of my knowledge. But if you look at the new tool that what is being mentioned about the BNP, I think it is pretty easily available in the hospitals and easily accessible. And that publication is really helpful that if you can just switch to BNP and troponin I, if it's possible, if your hospital do not have that facility available, because I think it's a pretty comparable tool and it's also validated. So rather than focusing on adjusting it, I would prefer that you can look into this model with the BNP and troponin I model. That I think is more feasible.
Mute yourself.
Yeah. Okay.
Okay. Thank you, Dr. Raza. I think that was an excellent question. I think that the BNP is certainly more widely available and might be much easier to use as a staging tool than the more specialized NT-proBNP. We did have another question also for you from, I believe, maybe one of our internal medicine colleagues, but she, or I'm not really sure, but the question was that, you know, we see a lot of patients who have a negative FCAP, but a minimally abnormal free light chain ratio, you know, very minimally abnormal. I know in my experience, I get some very, very minimally abnormal questions, but the question was, do all of these people need to be referred to the hematology oncology department?
That's a good question. So, and I think this is a very common question. And as a first-time hematologist, we see this entity a lot. I think each case needs to be interpreted case-by-case basis. Sometimes we see patients have amyloidosis only in the skin without SPAP and UPAP, but I still prefer they should be seen by a hematologist so that the proper workup is being done. Now, the patients who have chronic kidney disease, and we do see that they have mildly elevated free light chains, the free kappa, we all know that their free kappa are slightly elevated and it's adjusted, as I shown in my slide, that you have to adjust the model. Like it's not accurate between 0.25 and 1.6 for everybody. So you have to have multiple data points. You look at the light chains elevations on multiple times, and then you can adjust it, what their renal functions are. And just to be sure that you have done the monoclonal protein workup with the 24-hour urine protein electrophoresis and the serum protein electrophoresis, that would be very helpful. So you don't need to send the patient to hematologist. However, if there is a suspicion that this patient have maybe a cardiac amyloidosis with a minimal light chains, I think the specialist would be the organ-directed approach with a specialist, cardiac amyloid specialist who can look into the heart, and you can take it from there. And I think that would be the right way to address these mildly elevated light chains.
I completely agree with you, Dr. Raza. I think that's a good point. So we also had some very good questions for Dr. Sanchorawala, if you are still there. So the question for you was, in the era of Cyborg and daratumumab, and in the absence of any comparative trials, what is the evidence that stem cell transplant is the optimal therapy for AL amyloid, especially in patients with higher pre-transplant risk factors? And this is given the fact that sometimes patients are being treated and transplanted in non-expert centers outside of your own, obviously, and those patients may have higher morbidity and mortality.
I think this is a great question because the answer to the question is in the question, that there are no comparative data There is no randomized clinical trials. We are very anxiously awaiting the results of Andromeda clinical trial, which is a randomized clinical trial of Cyborg plus subcutaneous daratumumab versus Cyborg alone in patients who are treated with who are newly diagnosed patients with AL amyloidosis. And I think the critical issue to me is that, you know, I love Cyborg and Dara. I love Cyborg, I love Dara, I love the combination. They have very, very high responses. They are very well tolerated. What we don't have is what is the progression-free interval? What is the time to next? Because these treatments cannot be delivered for 4 years and 5 years and 6 years and 10 years. So we don't know what their response duration is going to be off therapy. If we do it for 2 years versus if we do it for 6 months, if we do it for a year, what is the duration of response off therapy? I think that is going to be the critical point. Obviously, the financial toxicity of all these agents is going to come into picture as well, because, you know, I think that stem cell transplant is a one-shot deal. And, you know, as I showed in my last slide, the quality of life is also generally improves post-stem cell transplant. And sometimes, you know, bortezomib-based treatment, when patients are continuously getting it, is difficult to tolerate. But we do need some competitive trials. We do need some randomized trials to really, really figure this question out.
I unmuted you.
Thank you, Dr. Sanchorawala. I have a question for you. Sometimes we see in the clinic within very advanced stage for AL amyloidosis, and they cannot tolerate these treatments because of the significant heart failure issues. What do you do in your center? Do you do upfront transplant and then after that you start the induction, or what's your center preference?
So for advanced cardiac amyloidosis, when it is isolated to the heart, we do at least consider heart transplantation. Again, one has to understand that heart transplant is not that easy and readily available. Donors are really definitely a paucity. The heart, you know, the donors are not available. Furthermore, if they have other organ involvement, heart transplant is not really being performed. So if it is truly isolated heart involvement with significant advanced heart failure and significant, you know, low blood pressure and other issues associated with advanced cardiac involvement, then we would probably refer the patient for an opinion at Mass General Hospital for a heart transplant evaluation. If heart transplant is performed, then we would definitely 3 to 6 months later suggest stem cell transplantation. Again, you know, I think that of the patients that I've referred for heart transplantation, only minority handful of patients do get heart transplantation. So I think if advanced cardiac involvement is present, I would prefer a bortezomib-based regimen, but I would do no harm first should be the policy. I usually do single agent bortezomib, start out with 1 milligram per meter square weekly, gradually increase it to 1.3 milligrams per meter square, then add 10 milligrams of dexamethasone, then increase it to 20. So it's, again, a stepwise approach to make sure that we are not doing any harm to patients who have significant cardiac involvement. Also, I think bortezomib does unmask autonomic neuropathy at times and leads to hypotension. So I think in patients with advanced cardiac involvement, it becomes very hard for blood pressures to drop even a little bit.
I agree. Thank you.
All right. We also did have a couple questions for Dr. Picken, if Dr. Picken is still with us.
Yes, I am.
All right. So one question that came up for you was that we commonly see elevated creatinine in patients with wild type TTR amyloidosis, even when cardiac output is not very low. And these are usually older patients, and it's always assumed that this is due to the beginning of cardiorenal syndrome or unrelated renal impairment. So the question for you is there any evidence that these patients have renal amyloid deposition?
That's a good question. I think, and the answer is not straightforward because we don't have much data available. The current thinking is that wild type TTR tends to have systemic distribution, largely limited to vasculature. That's what we see in the gastrointestinal tract. That's what we see in the kidney. We may have some interstitial deposits predominantly in the medulla. So, there is essentially no data about any significant glomerular amyloid deposits in wild type TTR.
Sorry, you were going to say something else.
Well, and similarly, I would say there is also not much data available whether or how many patients may have neuropathic symptoms. But I think as far as the latter is concerned, we really need to look into that. For kidney, it's more difficult because we don't have that many biopsies. So it may be multifactorial.
Okay. All right. Well, thank you very much. That was one of the questions that came for you. Another one of the questions that just came in for you was that with the discovery of, and you'll excuse me that I...
yeah, I saw it. Yes, excellent question. Let me just read it. Yes, so with the discovery of the role of ApoL1 in renal disease, do you believe FSGS, focal and segmental glomerular sclerosis, will be reclassified as a type of amyloidosis? This is a very sort of broad question. I mean, you all know that ApoL1 really revolutionized our approach to FSGS, to renal pathology in African Americans. Yeah, I think it's an open question at the present time. I don't have an answer, but it's something to think about. And I like to also add, if I may, we have to think about amyloid big time. I mean, in a very broad sense. It is amyloidogenesis in a way. It is a recycling issue. You have certain tissues, certain cells are producing these abnormal defective proteins. Under normal circumstances, they should be eliminated by the protein quality control systems, but when these systems are being overwhelmed, they proceed toward fibrillogenesis, and they ultimately clutter our organs, our body, our brains. So yes, I think the time will be coming soon when we will be looking at amyloid in a much broader sense. I also wanted to say that there are positive things about amyloid. There is a lot of applications for beta-pleated sheets, you know, in industry and other things, which we obviously won't talk about today. But yeah, amyloid is big, so think big thing.
Thank you. We actually had a question amongst ourselves here. Actually, Dr. Raza had a question for you, Dr. Picken. He wanted to know, how commonly do you see the amyloid heavy chain or heavy chain deposits in the kidney and amyloid?
Well, uncommonly. It is uncommon. Okay, I don't know whether I may have missed any instances, because in order to detect it, one or say that there is no heavy chain presence with confidence, one would have to use specialized antibodies. You know that the heavy chains are not complete, may not be picked up by regular antibodies. If they are only limited to heavy chains, if we see deposits, we don't see anything else. I think if we do mass spec, we can get an answer. So one has to sort of think, if things don't measure up, don't add up, right, then one has to look at other techniques.
Thank you. Brett, did you want to ask a question?
Yeah, I had a question for Dr. Sanchorawala, if she's still there. Maybe we can help unmute her.
I'm here.
All right, Dr. Sanchorawala, if you're still there, I have a question about doxycycline. You know, it's a medication that has been published on for AL and ATTR amyloidosis, potentially being helpful in AL as an adjuvant to CyBorD or other initial therapies. Is that something that you use in your center? And do you use it for all patients or just certain types of patients?
So that's a great question. And the doxycycline actually is very close to us because it was the whole concept of doxycycline was, tested here in a transgenic mouse model of AL amyloidosis in actually David Sullivan's laboratory right at Boston University Amyloidosis Center. And in those transgenic mice, the mice that were fed doxycycline, the amyloid deposits were much less than the mice that were not fed doxycycline. And these were all, this was published by Jennifer Ward in Blood. And so we were very, very impressed by that. And we did have a phase 2 clinical trial where patients received doxycycline, and we did not really see any improvement in cardiac biomarkers or in surrogate markers of renal involvement like proteinuria. It was not just for cardiac amyloidosis, it was for all types of organ involvement. And we did not see any significant improvement. What we noted was that there was significant toxicity, specifically the phototoxicity and GI toxicity were significant, that patients would not be able to take doxycycline continuously. Having said that, there is also a paper from UK National Amyloidosis Center, which was not a randomized control trial, but it was a case control matched paper where patients with advanced cardiac involvement were treated with either proteasome inhibitor-based therapy or proteasome inhibitor-based therapy plus doxycycline, and the survival was, it was compared to the historical control where they were treated with CyBorD, and the survival was much better. They did not really see too much of phototoxicity or GI toxicity. So in our practice, in standard practice, we don't generally recommend doxycycline for AL amyloidosis. Speaking with the investigators from NAC at the National Amyloidosis Center, they do believe that it should be combined with a plasma cell dyscrasia-based therapy and not by itself. If a patient is referred to us who has been on doxycycline and on CyBorD or some other sort of treatment, we don't generally, and if they're tolerating it well, we don't generally discontinue it. We would continue it, but we don't really recommend for anybody to really start it. So I think that is just our bias. We don't really have any proper control studies to really prove that doxycycline works or doesn't work.
Great, thank you. And maybe the amount of phototoxicity depends on what part of the country you live in. If you live in Boston or if you live in Mayo, maybe a little bit less than our colleagues in the South. Another question for Dr. Picken is that, different centers sometimes use different stains for the initial stain for amyloidosis, either Congo red or thioflavin S or T. Do you see any differences in those stains? When would you use one versus the other, or is it just a facility preference?
Can you please unmute me? I am muted. Oh, okay, you can hear me. So ISA, International Society of Amyloidosis, is its recommendation listing Congo red stain, and this is a gold standard. I personally don't use to any big extent thioflavin stain, but I know people who use it, find it easier to interpret. And I think maybe it should be made more popular if it works for people. It still requires fluorescence microscope and certain expertise in usage. But I think that for the purists, it will have to be verified with against Congo red stain. Whatever works, if it's helpful, by all means. I think among all other stains which are available, thioflavin is probably the more sensitive than SAB, sulfated Elcian blue, which stains gags, for example. So I think whatever we can propose for people to use to screen for amyloid, ultimately you will need Congo red stain, but whatever helps to get on the right track should be used.
Thank you so much.
Yeah.
Oh, thank you so much, Dr. Picken. I think we're going to go ahead and close for 3 o'clock. I thank everybody for coming, and I just want to plug tomorrow. We're going to be talking about ATTR amyloidosis. We have some excellent speakers coming up. So you can find the schedule at kcamyloid.com. So thank you. And that's the schedule there up for tomorrow. So thank you so much, and we will see you tomorrow. Take care, everybody.
Okay, bye-bye.